And while inserting the needle, as patient is anesthetized, there is no need of giving local anesthesia. And before starting, always check and always keep a finger in the mouth so that needle tip won't breach the oral mucosa. Once you stabilize the needle, say 2-3 centimeter, always go for some fluoroscopic use. Take as you can see, needle is going towards the mid-pupillar line and mid-zygomatic area, and that needle insertion itself is 2 to 3 centimeter lateral to the angle of the nose. As you can see in this view, now just enter the foramen oval. I will just stop here, and that after confirming the position, I've started inflating the balloon. Now, once you have a pear shape, you keep the compression to initially it's described around 90 seconds, but I keep usually 120 seconds. And after this compression, but during compression also the patient can have trigeminal depressor response. So you have to be careful. Those patients have cerebrocardiac, and some patients we have encountered a systole also. And some physician recommend use of pacemaker or keeping the defibrillator ready for this patient, because in one of our patients we have a systole, we have to resuscitate the patient, but the patient comes out very well. And once you have made good compression, you have to remove the whole of the equipment, catheter and needle in toto, and give a good compression at the insertion site for at least 5 minutes, so that there is no hematoma formation in the face. Time is over. Can I have 2-3 minutes? And regarding pain relief duration of shape and balloon, as I told you, the pear shape had maximum relief and good outcome. And this sensitive compression, pear shape, it has good compression, result in good pain relief in most of the patient. And avoid that balloon too much in, otherwise, especially if you are having dumb bell appearance, that means you are going towards the cranial fossa. Regarding pain relief, that is most important. And in our study, in our case series, we found that 99% of the patient have immediate pain relief. The moment you shift the patient to the ward, and once the patient come out of anesthesia, they take it patient, they are having good pain relief. And in most of the study, the pain relief is more than 94%. And as any of the percutaneous transfemoral technique, this patient can have some complication, especially paresthesia or sensory loss in the face and masseter weakness. Coming to masseter weakness is around 70%, 60 to 70% after percutaneous balloon compression. I think this is maximum in this procedure. And some patients may have hypoesthesia in the face, but usually these things resolve out between 2 to 3 months the patient will have. Thank you very much. Delete कर देना है.
Sir, load नहीं करें. Sir,
a 4 French catheter that usually maximum you can inject is 0.7 as recommended in the 0.7 ml. But you usually use 1 ml. We have done a number of occasions. You can simply use, if you are using fresh catheter, you can simply use 1 ml. And 1 ml you have good shape, unless there is an anatomical variation of the buccal shape. So most of the time you will have a pear shape with 1 ml. Pardon? Pressure we don't have any equipment, but nowadays we are having this usually 1.3 to 1.2 neutron. But in most of the cases we have not monitored. We go by pear shape appearance of this and keep 120 seconds. And the moment you start compression, inflating the balloon, the patient usually, in around 80% of the patient have trigeminal depressor response. They have cerebrocardiac unless you are careful. But in literature, people recommend the use of atropine, prophylactic, but we don't use it. If you have trigeminal depressor response, that is confirmed that we are at the right place. So if you have cerebrocardiac, just deflate the and then you can give some atropine and later on reinflate the bone. Mhm. Mhm. No, actually in APU, if you see, if you bring the petus part of the temporal bone in the inferior part of the orchid, and if you follow that petus part of the bone, there is a slight dip in the middle aspect of the petus part. That anatomically suggests it's a beginning of the porous trigeminy or Meckel's cave. If you take this, and we have in RFA also, we have injected some dye also and seen the spread. And if you are using lateral view, if you use that where the clivus transect the petus part of the temporal bone, you should not exceed 2 to 3 meter above this line. But that means you are near the ophthalmic division, or you will be bypassing the porous trigeminy. So maximum, say, if you draw a line from the base of the pituitary fossa to the clivus, okay, that's a line which should not exceed for V2, V3 division. Okay. If you another 5 millimeter below that, that means you are near the V2 division. And if you are another 5 millimeter, that is 1 centimeter, that means you are at the V3 division. There is another way. Some people are recommended where the this clivus joins the transect the petus part of temporal bone. You should always insert the needle 2 to 3 millimeter enter with that cross line. Okay. And if you make that area as a 12 o'clock, image a circle, okay, for 10 centimeter, that means you are going towards the V3 division. For 11 and 12 position, that means you are going towards the V2 and V3 division. Mm. 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 Pardon? Mm. Dr. Saini is one of the pioneer of triangular ablation techniques.
Surgery and started doing it, but it was very expensive and we are getting the huge one and sterilizing and using. So we did not do that because all the time all
the very first study that was published in literature from India is by Dr. Nataraj from RML Hospital. He has published 60 patients of percutaneous balloon compression in early 80s. And
anhydrous glycerol. Yeah, the question is not that. You are doing a procedure in a 500 cases.
so we have seen, we have trained under guidance of Professor Dureja, but he used to do RFA and all that. Thank you. Thank you.
When you are discussing,
I'm inviting
first should be ready with the slide.
Dr. Navdeep Sokal for his talk.
The next speaker should be ready with the slide.
So, good morning everyone, and today we are having a very wonderful weather in Delhi. So hope you have enjoyed, and now we are enjoying the very good academic feast, and I will congratulate all the organizing committee for this. So we will be discussing maxillary and mandible blocks for trigeminal neuralgia. Though both these divisions can be taken care at the gastrointestinal ganglion, But there are other approaches also where we don't want to enter the gastrin ganglion, but we tackle these little bit lower and with other approaches. So as you can see here that our face is very richly supplied by the various nerves, and most of the sensory supply is by the fifth nerve, but rest also contribute like 7th, 9th and 10th nerve. And as you come to know that there fifth nerve like V1, V2 and V3. So extraoral route we don't ablate V1, but V2 and V3 we want to ablate. So first I am going to discuss maxillary. So anatomy is very important for whenever we are discussing about trigeminal nerve and its branches. And one thing I want to tell you that whenever you are doing any manipulation with any of the trigeminal nerve, the monitoring is most important thing, because the TCR is maybe a complication and it may be disastrous for the patient. So as you can see here, so this is trigeminal ganglion, this mandibular nerve coming out of foramen ovale, this maxillary foramen rotundum, and this is ophthalmic for the superior orbital fissure. The maxillary nerve is a pure sensory nerve that begins at the gastrin ganglion and travels anteriorly and inferiorly along the cavernous sinus through the foramen rotundum. So this is foramen ovale and the blue one is foramen rotundum. So again, this is really important because in trigeminal, if you don't know the anatomy, it may be difficult. So this is the trigeminal ganglion. Then it's the maxillary nerve comes through the foramen rotundum, then in the pterygopalatine fossa, where it gives most of its branches, like pterygopalatine nerve, which supplies the nose and palate. Then the zygomatic nerve, which further divides into zygomatic facial and zygomatic temporal. Then it gives the posterior superior alveolar nerve, and the infraorbital nerve, which travels through the inferior orbital fissure and comes out infraorbital foramen and gives further branches. So we mostly try to ablate this in the pterygopalatine fossa, and territories, as you can see here, the lower eyelid, the ala of the nose, the cheek, the upper lip, the cutaneous zygomatic and temporal area, and it supplies superior teeth, the palatine bone and maxillary sinus. So what are the various indications for the diagnostic and therapeutic management of trigeminal neuralgia? As we adjunct to GA for the major cancer surgery to maxilla, ethmoid sinus, maxillary and infratemporal fossa. In children, you can have wonderful postoperative analgesia if you give bilateral maxillary block for the repair of congenital cleft lip and palate. And in maxillary trauma and maxillary osteotomy, the block may be used. So along with the long needles and syringes, if you are doing pulse radiofrequency, then the 5 mm active tip is desirable, and local anesthetic and neurolytics can be used. Neurolytic we mostly use 6% phenol and 40 to 50% glycerol or absolute alcohol. So first I am describing first infrazygomatic. There are two approaches for the maxillary: infrazygomatic approach and suprazygomatic approach. So first, what you need to do, you need to identify mandibular notch, and you can ask the patient to repeatedly open or close his mouth. And keep your finger in the just at the mid-zygomatic bone, and when the patient will clench his teeth, you will feel the notch there. This is between the convoluted and cornuate process. Then the needle is placed just perpendicular to the skin as a posterior inferior aspect to the notch, and needle is advanced till you touch the lateral pterygoid plate, which will be at the 4 to 5 centimeter. Mostly this comes at the 4 centimeter. Then the needle is directed anteriorly and superiorly towards the root of the nose and advanced in the pterygopalatine fossa until a paresthesia is obtained. And it is always important to obtain paresthesia because it increases your rate of success. So if you are just blocking it, up to 5 ml of local anesthesia injected, but if you are using neurolytics, then just 1 to 1.5 ml is enough. And for the, if you are using the pulse radiofrequency here, the sensitive stimulation at the 50 Hz, 0.2 to 0.5 volts, and motor stimulation the 2 Hz, 0.6 to 1.2 volt. Somebody may ask that this is pure sensory, then why? What is the role of motor? If there is motor stimulation on the maxillary, then you may guide the little bit forward. And the pulse rate of kiss is done at 42 degrees Celsius for 2 to 3 minutes. The same procedure can be done under fluoroscopic guidance. Here you first go in the lateral view and reach the superior 1/3 of the pterygopalatine fossa. And in the epi view we confirm the depth. The needle tip should not cross the lateral wall of the nose. There are complications of this technique that you may puncture the maxillary artery, the posterior pharyngeal wall, the submucosal abscess may be there. If you go through the superior orbital fissure, there may be orbital injury which may range from ophthalmoplegia to the complete blindness, and you may enter the subarachnoid injection may be done if you are too deep. The other technique is suprazygomatic. This is again landmark based technique. So our entry point is just above the suprazygomatic arch and the posterior wall of orbit. The needle is inserted perpendicular. Then it is advanced to reach the greater wing of sphenoid, which will touch 1.5 to 2 centimeters. Simply in the temple area you advance, and the sphenoid bone will come. Then you withdraw the needle and go in the posterior and caudal direction, as you can see here, and advance till you reach the pterygopalatine fossa, and you negative aspirate for blood and find paresthesia, and then you need to inject the drug. The same procedure can be done USC guided also. Here the landmark is anterior is maxilla and posterior is sphenosinus, and this is pterygopalatine fossa. In the base of this pterygopalatine fossa you see the maxillary vessels lies, and maxillary vessels lies ventral and inferior to the maxillary nerve, and the needle is advanced using an out of plane approach. So the needle is so this is the position of the probe. This is placed in the infrazygomatic area. And the real-time ultrasound guidance allows direct visualization of the internal maxillary artery, identification of the needle tip, as you can see here is going, and a spread of local anesthetic solution within the pterygopalatine fossa. Then the terminal branch of the maxillary nerve is infraorbital, and which comes out of the infraorbital foramen, and it again is divided into 3 nerves: the inferior palpebral, the lateral nasal, and superior labial nerves. So it supplies the skin and mucous membrane of the upper lip, the lower eyelid, the cheek between them, and the lateral side of nose. And this can be simply blocked at the inferior infraorbital foramen, which lies in the midline of the pupil and just 1 centimeter below the the orbital rim. So next is mandibular nerve block. This is the third largest nerve of the trigeminal, and this is only mixed division. The rest two are only sensory, ophthalmic and maxillary, but this is motor as well. The motor root arises directly from the pons. It doesn't come from the gisant ganglion, but it carries with the mandibular nerve, and both divide just after the foramen oval, just coming out of the foramen oval. So the gisant ganglion, so this was foramen rotunum, this is foramen oval. It goes like this. Then it gives its motor branches to both the pterygoids, medial and lateral pterygoid, then masseter and deep temporal, and then the sensory are the buccal nerves, temporal and buccinator, and other important the auriculotemporal, the lingual and inferior alveolar nerve, which exit as a mental nerve literally. So this mandibular nerve supplies the ipsilateral mandibular bone, the lower teeth up to the midline, the buccal and lingual hard and soft palate, anterior to tongue of the anterior 2/3 of the tongue, the floor of the mouth, external acoustic meatus and auricle of ear in its anterior zone, the skin over the jaw, the temporal area except the area of the angle of the mandible. This is not supplied by the mandibular nerve, which is supplied by the superior cervical plexus. So indication as the non-malignant chronic conditions like trigeminal neuralgia, the vascular neuralgia, the post-herpetic neuralgia, passenger cancer or trauma, and surgery on the lower lip or anterior 2/3 of the tongue. So preparation is same, and the monitoring is must for any trigeminal block. So pulse radio frequency can also be used, and position is supine. And if you are using C-arm, the patient to be placed in supine position, and we first use in lateral, then AP view. So surface landmark is same here like the maxillary. We are again using the mandibular notch here, but what we do, we just enter the skin perpendicular to the mandibular notch. Then we advance to the infratemporal fossa with the lateral terminal plate serving as a bony endpoint, and the depth is usually at the 3 to 4 centimeter, mostly 4 centimeter. And then for the maxillary we advance it to superiorly and anteriorly, but here we advance it posteriorly and little bit inferiorly. And then we see the paresthesia, or we can see the mandible elevation twitch. The minimal intensity of the stimulation may be around 0.2 to 0.5 milliampere. And then 5 ml of local anesthetic injected. If you are using neurolytic, again the 1 to 1.5 ml. And the neurostimulation is associated with high success rate. When we give motor twitch, there will be twitching of the mandible. The complications are again because this is mandibular now, and you may enter either in the middle artery or the maxillary artery. There may be injury to pharynx if you are going a little bit posteriorly. So intermaxillary and middle meningeal artery can be injured if you have inserted the needle too high in the mandibular notch. Injury to pharynx may be while walking posteriorly of the lateral pterygoid plate, because just posterior of the pterygoid plate, if you go more posteriorly, you may hit the superior constrictor muscle of the pharynx. And the large volume of local anesthetic solution, the nearby nerves like facial nerve paresthesia may be there. The other complications which are maybe sometimes really dreaded, the prolonged vertigo and ataxia after mandibular nerve block, maybe if you injure the auditory tube while going through the pharynx. Sometimes transient asystole, as Dr. Mohan was telling, that due to trigeminal cardiac reflex, patient may go in asystole and CPR may be needed. So these blocks are really very risky, and a good monitoring and anesthesia help should be there. And sometimes we have seen one case of mandibular displacement. When there is pain, there is severe spasm of same side of muscles, and to maintain the neutrality of the mandible, the other side of muscles also go in spasm. As soon as the pain was relieved for that person, the other side of muscles pulled the mandible out of the mandibular notch and the mandible was deviated. So pain on the same side was relieved, but then there was pain on the other side. So this was later sent to the dental clinicians, and they fixed the jaw. And this is another, this is a terminal branch of mandibular nerve, that inferior alveolar nerve, which comes out of the mental foramen. This emerges at the mental foramen and divides into 3 branches, and this supplies the labial mucosa of the lower lip, gingiva, and the skin of the chin. And the same thing can be taken with the ultrasound guided also. So there is supraorbital foramen, infraorbital foramen, mental foramen. These all lies in the mid-pupil plane, and with the USC guidance you can see that there is dip in the bone. So I think, and you can simply block this mental foramen here. So thank you. Yes, sir. Yes, sir.
They will put an hand. I have several tooth extractions. I know how they put it and how effective it is.
Yes, sir.
And mandibular block is very commonly used by dental surgeon for extraction of the molar, any tooth.
Yes, sir.
That is very.
So they give.
Maxillar nerve directly pierce the hard palate directly, and they don't block maxillary nerve, but for mandibular nerve, for lower jaw, they block it.
So dentists mostly use the intraoral blocks, and we use here mostly extraoral because both the techniques are described, but we mostly use
They
extraoral.
must be doing several blocks of mandibular.
Yes, sir.
They very successfully they block the mandibular nerve. Okay. Any other question? If there is no other question, give me a big hand. Very nice.
There is no hata.
So we thank the speakers and the chairpersons of this session, and now we'll break for tea. We have a lot of operative cases lined up, as you can see in the schedule, and we'll come back here at least in 20 minutes. So by 9:40 we should all be back. Thank you.
Okay, sir.
हेलो
हाँ गिरीश जी,
हाँ जी
हाँ बिल्कुल क्लियर है।
ठीक है
ओके,
ठीक
हाँ
है
जी, हाँ जी।
ठीक वीडियो में
राय सर माइक से बोलना एक बार।
हेलो हेलो
हेलो गिरीश जी,
जी
1 मिनट में ओटी से चेक करा रहा हूँ। लैपटॉप की ना। हेलो राय जी,
हेलो
राय सर आपकी आवाज नहीं आ रही। अरे यार अभी अभी करवा लो जो करना 5 मिनट में। चलो चाय पी के आ जाऊंगा।
ऐसे कैसे कहोगे? मैं तो गया और क्या जाऊँ?
अभी बात तो करो।
हाँ, मैं बात
माइक
कर
देखो।
रहा
हेलो माइक देखिए ऐसे चलो। अरे वो हम खुद को बनेंगे। हेलो डॉक्टर
हेलो
अनुज,
यस सर।
ये OT1 जैसे केस का ध्यान रखियो, केस भी लिखना पड़ेगा।
हाँ सर, वो बना रखा है, पता नहीं ना कौन सर्जन है। ये देखो,
हाँ ठीक है।
ये पहुंच को देखा OT-2 में।
अनुज क्या हुआ माइक का?
माइक चेंज कर रखा था।
ओके।
हेलो राजेश सर। हाँ जी बिल्कुल क्लियर सर। बोलो।
4 नंबर है।
हेलो
हेलो हेलो अंग्रेजी जी।
हाँ राजीव जी।
हाँ जी हाँ हाँ कौन?
हाँ जी
आवाज
सर।
आ रही है?
हाँ जी सर।
ठीक है।
हाँ ठीक है।
आज तू नीचे कैसे आया? तू तो ऊपर होना चाहिए।
सब बस ठीक है सर, डॉक्टर साहब ठीक है। ओके।
हेलो
दूसरी OT में चला दो बात है।
हेलो
ये
हेलो।
OT।
हेलो
हेलो।
यस सर।
हाँ जी सर, आवाज आ रही है आपकी।
ओके सर।
ठीक है, बढ़िया वीडियो
बढ़िया।
बढ़िया सर।
ओके।
अब वो दे दो दूसरा, तीसरी OT।
हेलो।
ठीक है।
हेलो
सर 2 ही OT है।
ठीक है सर, 2 OT है ना?
यस सर।
ठीक है, थैंक यू सर।
ले जाएगा तो ले जाए। टाइम परमिट होगा। किसके?
Hello? OT1? Hello?
Hello, yes, sir.
OT1, be ready. We'll be joining you in 5 minutes. Delegates are having breakfast. Maybe in 5 minutes we'll be ready to join you.
Okay, sir.
So by that time, be ready with your presentation. Sir has reached. Hello. Okay, sir. Okay, sir. Sir, we'll join you in 5 minutes, sir. Thank you, sir.
Uh, for this session, we have uh, Dr. Pankaj, Professor Pankaj. He is a senior faculty now from our institute. We also have Ramesh. I think he's not there. Dr. Amol is there. Ramesh ऊपर गया है. अच्छा. So Dr. Ramesh and Dr. Amol will be moderating this session. I would request, can we connect to OT1?
Hello.
Yes, can we?
Good morning, this is Abhishek. I will be presenting the first case, sir.
Yes, Abhishek.
Mr. Ved Prakash, a 49-year-old male, sir, he came with complaints of left-sided lancinating pain in V2, V3 distribution since last 8 to 9 years, sir. These pain episodes were aggravated on biting, chewing, or taking hot or cold foods. On examination, our patient didn't have any deficit, sir. Motor and sensory examination within normal limits in the terminal nerve distribution, and then there were no cerebellar signs. So on MR imaging, there is this MR was done from outside, sir. And
I will not take that. If it is not, I will never do that. I don't want to introduce anything into that area.
So even is not blood or CSF?
See, if it is a very high risk patient with cardiac abnormalities and all, I do use it, but generally no, I would not recommend that. We use Zylocard, which is preservative free, 0.2 to 0.3 ml, but with this CSF and other things, better to avoid it. Even though he is anesthetized now, follow. So we can start the simulation. Udhar janiye, please.
Sir, one question.
Yes. एक मिनट सर सर प्लीज we start it, no? हाथ पकड़ के रखना अगर ज्यादा होगा तो और प्रोपोजल देंगे स्टार्ट चलिए स्टार्टेड हो थोड़ा प्रोपोजल और दे दो.
So you set the temperature at 50
What is
degrees.
the protocol? I start with 50, 60 seconds, 60, 60 seconds, 70, 60 seconds, 80, 60 seconds, that's it.
And do you do one or you do twice?
80 I do twice. So he's okay. We don't produce deep anesthesia. He's okay. Oxygen is on. Keep a watch on the saturation. My ears are always hooked on to the monitor. Before anybody else recognizes bradycardia, my ears would. It's like 45 years of listening to the monitor. Yeah.
What do you do if there is a bradycardia, sir? You
Atropine.
stop the lesion?
No need to stop. The bradycardia will only happen once you enter the foramen and touch the ganglion. Otherwise, there won't be any bradycardia. So we have gone to 660 now. The second lesion is at 60.
So needle you have not touched, we are just making 2 lesions.
This is the second lesion now.
Second.
Needle I am not touching because I am getting good stimulation, so I don't want to touch. And he will get up absolutely pain free. So although some people say that it takes 1 week, 2 weeks, but the real success is that patient gets up without pain, and he would never have that same pain again. The duration of relief would be from 3 years to 10 years.
So what is the dial doing, sir, on the output control dial? What is that?
Output, this output is coming up depending upon the impedance and depending upon the temperature and all.
Right.
This we are not controlling.
Okay. So the dial only controls the temperature.
We control the temperature, time, that's it.
That's it.
patient. From that severe episode of like it's called a suicidal disease also, to absolutely no pain. And I think it's worthwhile for everyone to learn this and practice this in their cities. Uh, See, yes. So if nobody is asking me the complications, yeah. So the complications like immediate would be infection, but we always, this is the only procedure where we give a prophylactic antibiotic. So I will give a monocyte 1 gram immediately, and after the procedure I give paracetamol IV infusion for the relief pain which generally occurs, and continue antibiotic for 5 to 7 days. That is one. And give an NSAID also, because sometimes the pain of this procedure can last for 2 to 3 days. Okay. The other complications are generally seen are these, like if you are doing V2 particularly, and if there is a little bit of involvement of V1, then this hyperesthesia or keratitis or all those things, if the V1 is involved. So while doing V2, you've got to be more careful. थोड़ा propofol दे दो sir.
How frequently can you repeat this procedure, sir?
हाँ करो जो मर्जी करो, मेरा तो हो गया. जी sir.
How frequently can you repeat the procedure?
So as long as, I mean, like the patient comes back to you after 3 years, you got to repeat it. Generally they won't come to you for at least 2 years, 3 years, 4 years, sometimes even 8 years. So whenever they come back, you have to do it. But at least compared to the alcohol blocks which generally last for 9 months to 1 year, this lasts for a pretty longer period.
Okay.
have to do the stimulation. So I'll give more time now. The reason is we just have one machine as of now. So we are using it in both the OTs. So to begin with, I want to share that, this should be.
The camera will focus on the X-ray monitor.
Yes, Ashish. So this needs to be flat.
Right.
Then you have a good cellar and the clivus.
Right.
So first things first, see the location of the needle in relation to the hard palate.
Right.
On a lateral film, it is either in the posterior 1/3 or behind it, as in here. The next important thing you have to observe is the location of the petrous temporal. So where the petrous temporal meets the clivus, just almost about 4 or 5 millimeter above that is your foramen ovale and entry. So truly the entry is here, where the clivus cup anterior portion toward the sphenoid sinus is sort of merging with it.
Right.
So there you enter and then you reach to the clivus. Okay. Now, I'll show you the oblique view which sir was just sharing.
But you usually do in the lateral view.
I use both, but most of the time I'm very comfortable doing just the lateral. So here you see the foramen ovale. This gentleman, he has trigeminal neuralgic pain in V3 and V2 for last 2.5 years. Severe, spreading towards the posterior part of the head as well, above the ear and a little behind that as well. And now the medications are not working. On MRI, basically you have vascular compression on either side, but obviously he has a left-sided problem, so we are doing it on the left side. And here if you see, this is the mandible, and here is the third molar. You can see the foramen ovale. You have to find the maxillary sinus, just lateral to it you will find it, and this is almost mid-pupillary line where you are going.
Right.
Now the position of the patient is very important. There is mild extension, but the important trick here is when you're doing a lateral X-ray, sort of you have to see that it's all parallel. So first what I'll do is I'll break the parallel nature. Abhi shoot kijiye. Okay, now look here.
Yes.
If you look at the clivus, though they
Camera be focused
monitor
center the image. Yeah.
आप थोड़ा सा इधर नीचे की तरफ लाएंगे, हल्का सा.
Now we can see.
Yeah. So if you look here, you're not able to see the clivus very well.
Right.
Now have a look. अभी एक मिनट. अब shot लीजिए. अब shot लीजिए. So all this is not good for you. अब shot लीजिए. All these images, नहीं ऐसा रख लीजिए. हाँ अब करिए. You appreciate now?
Yes, yes.
So now we are like bang on and we are ready for stimulation. What I am using currently is stimulation कर लीजिएगा 50 hertz, 1 millisecond with we'll start with a voltage of 0.3.
Camera can be focused on the
0.3
generator.
So Ashish, the patient is sedated.
Yeah.
You are given.
No. Patient is not sedated. Varun has just injected some amount of fentanyl, and because I was able to get it on first pass, so we did not sort of require it.
Right.
एक shot लीजिए. Yes, this is all just about that. It gives you a basic idea. That's about it.
Can you focus on the machine, radio frequency
Yeah,
machine?
shoot, please. Okay, I am pretty happy with this location to begin with.
Okay.
चलो अभी स्टिमुलेशन करना प्लीज ऑन करें. और बढ़ा लीजिए, और बढ़ा लीजिए, बढ़ाते जाइए. तकलीफ तो नहीं हो रही ना अभी कुछ? बड़ा ही 0.3 तक ले जाइए. हाँ, okay. Now stimulation on करिए. नहीं, 0.3 on. नहीं, you have to switch something to on. Okay, okay. अभी आपको कुछ लग रहा है? वैसे ही दर्द आ रहा है? आ रहा है? Okay. So he confirms that he is feeling the same amount of pain.
Right.
So और उसी जगह पर आ रहा है? हाँ, ठीक है. So now little bit of it. And आप 75 डिग्री पे ले जाइएगा. Now we'll give a cut RF. RF of 75. No, this is higher. Yeah. Okay, and for 60 seconds you can switch it on. Yeah, on please. You have given. Okay.
So, which hub we have targeted here?
You are targeting V3, right?
Right now V2. So as I told you, I tend to go to the higher dermatome first.
Right.
And then so he is having pain. As I am giving the current, he is moving and he is having pain, which sort of confirms. पकड़ लीजिए please.
So you don't give any kind of sedation or
Prior to test stimulation, you sort of either I give if I am not, quickly finding the foramen and if the patient is having lot of trouble. But there.
Sir, you are not going to do any motor stimulation?
I'll do for V3 now because once he is sedated, for V3 I'll do it. And I'll show you that as well.
Okay. So in
हो गया 60 seconds? नहीं. Okay. हो गया.
sir, just a question, Dr. Ashish Ramesh here.
Yeah, hi Ramesh.
If you lesion the V2 first and then come back to the V3, as Dr. Dureja was saying that probably the lesion effect will be there and you won't actually appreciate. Is that?
Yeah, so for that you just need to increase the test stimulation voltage. So instead of 0.3, because right now we got at 0.3. So if it is not coming again, we'll give it at 0.5 or 0.7. And also I look for the motor stimulation at this point of time.
Okay.
X-ray please. X-ray please. Okay.
Why this X-ray again, sir?
Because I'm pulling it out a bit for V3.
Okay.
X-ray please.
So you have given one
Shot of 75.
right, and then you pulled it out.
Shoot please.
How much do you pull it out? 1 millimeter.
Yeah, around 2 minutes. Like this location looks pretty good to me.
Okay.
Are you able to appreciate on this?
Yes,
Yeah?
yes.
Yeah. So I'll fire a test stimulation at 0.5. On कर लीजिए.
So you always do perform single lesion.
I go for 2 lesions, 75. So there's a little difference between this machine and yeah. So he has already started having pain again. Can you appreciate?
Yes, sir.
Yeah. So stop it. Continuous पे जाएंगे. So we have got a good stimulation at 0.5.
Right.
Yeah. So as you see, we can easily get it, and there is a lot of wincing. We'll do a 75 degree again. 75. Yeah. Start. You have to give it. अभी आप अच्छे से दे सकते हो.
So do we are not doing the motor stimulation here?
Yeah. So he was wincing and there was a lot of motor activity. Now, there is a difference between this machine and the machine that I have. The one that I have, it's not continuous stimulation. Sorry. Shiv Kumar ji, bus. So in that, there is a point stimulation. So when I push the pedal, at only that point there is stimulation. So I am able to see the jaw open.
Okay.
Like I had also shown in my clip that the lady's jaw was opening when I was giving a test stimulation.
Right.
So ये क्लब में yeah, everything was same. So we'll do something in reverse this time because we had to get the patient ready, and we just have one machine. Now Ravi and Datta are here. they'll sort of, as we are pulling out the needle, we'll demonstrate instead of putting in.
Demonstrate what?
Like how we went, how,
Okay,
you know, the position of. So come this side. You also come. So I'll remove the electrode as of now. So this is the electrode. Yeah, I am not sure what size sir used, but we have here a 15 centimeter
Okay.
needle and the probe. So we have used that one. Now, stilette please, sister.
This you have got, this is your own?
No, this you have. It
Okay.
here.
Okay.
But the problem was वो इलेक्टा के साथ compatibility नहीं हो रही थी connector की.
ठीक.
Now put your finger in. डाल दो तो हो गया. Yeah.
Is it possible the patient will bite it because of pain?
No, generally it doesn't. And you are outside the, मतलब you're towards the buccal mucosa. Feel हो रहा है needle? Okay. Now, Datta, you feel? Yeah, SPO2 come over. Okay.
Because you're putting in the needle and he has severe pain, he might just bite your finger off.
You can put a mouth gag and then do it, I
Okay.
think. That is more safer.
No, you don't really require it.
Okay.
Feel हो रहा है? Okay. एक X-ray shot लीजिए please. हाँ रख. Okay. Now धीरे से pull back करना about say half a centimeter, and then we'll show them. हाँ. Shoot करिए. Okay. So this is where the foramen ovale is typically there. Okay. जहाँ पर needle का tip है.
Right.
Okay. Now we are pulling it further. If you look down below, it is just crossing the posterior part of the mandible. The hard palate.
Hard palate.
Now pull it again. Now what Datta is doing is he is feeling the needle just lateral to the buccal mucosa. You are feeling the needle, right? हाँ. थोड़ा और pull करो बाहर. Yeah. Pull it further. Shoot please. Shoot please. हाँ निकालो और निकालो. निकालते जाओ. Shoot. हाँ निकालो. अब पूरा निकालो. So he has just gone there, and I want you to feel the third molar, and I want you to feel the mandible पूरा, and just locate where the needle is. You got it? Okay, so I am asking him to feel the third molar. If you appreciate on the X-ray, see we have just gone lateral to the third molar. Lateral में आप लोगों को दिख रहा है?
Yes.
Yes, sir.
Yeah, so you know you feel that on the through the finger as well. Take it out further. You want to try Ravi? ठीक है, इसको feel करने दो. So I think the procedure is done. The patient is right now under the effect of propofol. One event that happened was the SpO2 had come to around 89-90. So we did a simple jaw thrust, and again now it is at 99. Bas. So this is at third molar. Now just get it out. I also tend to give a little bit of ice pack, especially if I have had multiple punctures.
Sorry, what do you give?
Ice pack, just an ice pack.
Okay, ice pack.
Yeah. Just clean. One shot of antibiotic I use, and I taper the oxcarbazepine gradually. So if there are any doubts, I'll be more than happy to answer.
Dr. Ashish, how frequently you are able to taper and stop carbamazepine in such cases, and over how much period?
So generally, I take about 6 weeks to 8 weeks to gradually taper. There is also an element of psychological dependence of all these drugs. Like we saw what Deepak was presenting for pregabalin. Similarly, there is a little bit of for oxcarbazepine or carbamazepine group as well. So it is better to gradually taper it off. And as far as your question is, I would say around 50 to 60% of my patients, I really don't have a hard data, but I'm assuming that about 50 to 60% of my patients are totally off drugs, and the rest may be on minimal amount, mostly SOS basis.
Ashish, do you use baclofen in any of your patients?
Ashish, the question is, do you use baclofen in any of your patients?
Yes. So I use, so my first choice is carbamazepine or oxcarbamazepine. I have had limited experience with the newer carbamazepine, though it is an OD preparation, but not a lot of experience, just a few cases. So that is the drug of choice, I would say. The second is I go for pregabalin at 50 milligrams to begin with. If not, then I use either phenytoin or I use baclofen. Though I would say that lamotrigine also is very potent, but then as you are well aware that lamotrigine has a lot of dermatological and other side effects, and it has to be really gradually increased as vis-a-vis the other group of drugs which you can sort of increase a little faster. So lamotrigine for me comes a little later. But I must tell you, if the patient is not responding on carbamazepine and say
Deepak sir,
Yes.
sir, 2 minutes के लिए OT number 1.
Okay, Ashish, we'll have to interrupt you.
Sir,
OT2 connected sir.
just for 2 minutes, I wanted you to show my patient the Caesarean
Yes.
and he's
So Amol was just asking how we have marked here. So this is a true submental view AP, but it is not showing the foramen ovale very good because it is not tilted. We'll sort of tilt it, and here the image is very sharp and clear. So till the time they are preparing, I'll present the history. He is a 45-year-old gentleman with typical V1, V2 type of pain, and it's been again for last 2 to 3 years. He has been on Tegretol, pregabalin, and amitriptyline. So the first few months he had good relief, then gradual increase in the drugs. For last 3 to 4 months, these drugs have become ineffective. As such, he has not had any side effects of the drugs. Also, he does not present any history of any remission during these 2.5 to 3 years. The main trigger is touch and also a bit of chewing. Now, the challenge for us in this case is he has V1 and V2. Ideally, it is not RF is not a very good choice for V1 because of corneal hypoesthesia. So the way around is you can maybe reduce the temperature to 60-65 degrees for V1, and then V2 you go full throttle. So if we look at the MRI scans here, again no evidence of any mass lesion, and there is a small vascular impression on the root entry zone area. No chronic illness, and as I've told you, no other medications. So
sir, Dr. Ashish?
Yeah, hi.
For V1, if there is a V1 neuralgia also, so in such cases, do you feel, because you are a neurosurgeon, so MV would be better compared to the RF because of hypoesthesia and cornea and other associated complications?
Yeah, absolutely. I think if the patient wants to, so you should have all the 3 options again available. You should have, so MVD is a very good option. The second would be balloon, because the corneal hypoesthesia is reported quite less when you do a balloon compression. So sort of you can, if the patient selects a non-surgical route, then sort of you can try a balloon as well.
This means,
But just because of the cost, many a times I personally don't use balloon, and my experience with balloon is very limited cases.
This means the team managing trigeminal neuralgia patients should have skills of RF ablation, percutaneous balloon decompression, and MVD. All the 3 should be there in the armamentarium of the team managing such patients.
Yeah, absolutely. Absolutely. So Ravi is with me. I am helping him out. He is starting the case. So put the finger inside the mucosa. So let's see what the challenge is. Medial और टिप के पास से पकड़ना है, ऐसे जाएगा ऐसा hold it way. Yeah, good.
There might be a chance of buccal mucosal perforation sometimes.
Yeah, why not?
And what do we do then?
We change the needle or clean it.
Okay.
Dr. Ashish,
Dr. Ashish, I am having a thought in my mind. One side we are putting a needle which is going in the CSF because we get some amount of CSF outside the tip. Other finger is going into the mouth. How we are able to manage the sterility of the procedure?
So what I do is, first at times I will try to just keep this left hand out of the picture while I am handling the sort of needle.
Okay.
First. Second, if you understand that it is the tip that is going in.
Yeah.
And neither of my hands is touching that.
Yeah.
And then the electrode is going inside. And then you are creating heat inside.
What is the incidence of meningitis following this?
So for me, I have not had any meningitis. The reported incidence is less than 1%.
Okay.
Yeah. So Ravi has just started. Let's see where the needle is going. Shoot. Okay. So if we go here, we are going to enter the inferior orbital fissure. So we'll have to reposition. Okay. Good. Check. So Datta is there with us.
So we now redirect the needle more posteriorly.
Redirect it. Yeah. I'm trying to show you on lateral. You've already seen AP2 cases. Just want to demonstrate that. ठीक है? ठीक है? चलो आप अंदर डालो उसको. देखो वो वहाँ ऊपर जा रहा है. Push it a little inferiorly. Yeah. That would be better. Yeah. Go. शूट कर. हाँ, बस गो. Remain medial to the mandible, lateral to the third molar, inside the buccal mucosa. Okay, go. Can I check where you are?
One more question, Dr. Ashish. Once a patient develops failure following RF therapy, can it be repeated?
Yes. It can be repeated between say 3 to 6 months because you have to wait for that much of time at least.
And why this time gap is required?
That's what I said. You just need some time for it to recover and you to be sure that it is a failure.
Okay.
Go. Okay, go ahead. Yes, good. Go ahead. Go further. So, Datta, your position can be better. I'll show you how. No, wait there. So, you be there. So, if it is like this, can you shoot please? See.
What about this medial angulation? We are seeing that there is a significant medial angulation in the needle.
Yeah, there is obviously there will be a medial angulation because you are going from the lateral canthal line to the mid-pupillary line.
Okay.
So you see the difference between the अरे वो पुराना वाला दिखाइए. So just imagine with a little change of the angle, ये वाला नहीं. हाँ, ये वाला. So you see, on the left, the angle was a little different. He was tilted to the right, and I've just tilted the head a little bit to the left side. And on the right frame, you see how clearly.
We are not able to see both the frames.
Okay. एक
Can the camera be focused on both? Yeah, now it is visible, sir.
Yeah, so I'll show you. So what I'm trying to emphasize is the importance of the C-arm fluoroscopy image for you. So you see, when the head was tilted a bit, this was all blurry, not sharp, and when I've changed, it is so sharp. This is one of the best pictures you can get. And somewhere here should be the foramen ovale and here the entry and as we reach here. So hopefully we are correct. Chalo. Okay, Datta, go
So
ahead.
you did a video lateral tilt or?
हाँ करेंगे कर भी सकते हैं. No, you have to put. Always you have to put. Because you may take it out now if you are not comfortable. चलो, जाओ अंदर. Shoot करिए. Sorry, so the patient is wincing. वरुण. बस. राजेश जी थोड़ा सा.
Anything we have given the patient till now besides
He is
local?
giving fentanyl. He has given fentanyl.
Okay.
चलो, okay, go ahead. थोड़ा सा, I think you are a little inferior. Go a little superior. बाहर निकाल के थोड़ा superior जाओ. हाँ, go a little superior. बस इतना ही. हाँ. बस राजेश जी. Shoot please. Yeah, I think you should be able to find in here. एक मिनट हाँ. Head position सही नहीं है. Okay, shoot please. Yeah, this is a little better position, but I'll take it further. Shoot please. No, I'm not happy. Shoot please. Better. Now go. बस. Shoot. Bone आ रहा है क्या? नहीं, जाओ. बस. Shoot. Good. Go in. Bas Rajesh ji, you are cooperating. Shoot. Go in. Oh my God, Datta has done it in first go. Chalo, go. Go. Shoot. थोड़ा और अंदर जाओ. Brady. Okay, patient is having Brady. We'll wait.
Dattaraj has a stereotactic arm.
Yeah. So at this point, when they are waiting, let's get a AP view with a oblique. So, see, I hope the audience has developed the confidence that once they go back, they can really tweak it in.
It has been successfully cannulated by Dr. Datta. That means any of us sitting here can cannulate it because Datta has also not done before. It's so easy. That means it's so easy.
Was it a compliment?
No, I'm complimenting all the delegates. Because Datta also has not done any time. All these people have also not done. So all these people can also do it next time once they go back to their place.
Yeah. Shoot, please. Okay, so this is what you will get on AP, and now we will oblique it a bit. Oblique कर लीजिए. 15 degree.
AP image is not great, sir.
Yeah, we'll show you. हाँ, अभी shoot कीजिए.
Can it be centered, sir? हमको थोड़ा सा आधा दिख रहा है.
अंदर लाइन.
Battery is low. Please connect the CM.
हाँ, दिखाइए. Okay, so हाँ, बस के लिए नहीं. So you see, he has got artery, please.
We are not able to see the image at all. There is some problem in transmission, I think. Yeah. Camera का बैटरी लो है.
Connect the electrode, please. नहीं, अभी अपन lateral में डालेंगे. AP में कुछ नहीं करेंगे. अब दिख रहा है?
हाँ दिख रहा है sir. We are able to see the.
Yeah. So I had shown you the AP and now the oblique view. This is about 15 to 20 degrees. The mandible, the third molar area, either, and he is gone. And this is the sort of foramen ovale. He is more toward the medial side, which is good. And mid pupillary line के आसपास. So I think we'll confirm it again on lateral. How's the patient? Okay, so lateral. Now we are ready for the test stimulation. Okay, Ravi. Now you take up. तुम डालो.
The camera can move to the pulse generator.
No, hold the needle because okay. Another tip here that when you are putting in the cannula, you have to hold the needle so that the needle does not get pushed in, and keep on doing fluoroscopy. X-ray shot.
Dr. Ashish Tandon, can we improvise the needle by putting the marks on this needle? Means technological advancement, like we have on this EVD catheters. There is a serial centimeters written on that.
No, we can do it, but there is no set pattern that ये इतने ही सेंटीमीटर में मिलेगा.
Okay.
Because at 10 centimeters you will generally get it. हाँ, shoot करें please. Okay, Ravi, now push it in a bit slow. Hold it here, with your main hand, right hand से पकड़ो, and then push it in a bit inside. जा रहा, बस wait, shoot. Okay, go in further. हाँ, because V1 है तो पहले V1 कर लेते हैं. बस राजेश जी, shoot again. अरे नहीं गया बाबा, दाबना थोड़ा. बस हाँ, shoot now. Yes, now further, go further up to the clavius. थोड़ा ही जाओ. हाँ, बस राजेश जी, हो गया. Shoot. Okay.
So this advancement is basically to reach up to the V1.
Yes, up to the clival line. See, generally the text would say that never ever go more than 3 to 5 millimeters beyond the clival line, because then you can injure the internal structures. Okay, so
Can you repeat, Dr. Ashish?
never to go beyond 3 millimeters to 5 millimeters of clival line.
Okay.
But I'll show you something very important. See, यहाँ तो बहुत sharp है. Now just I'm tilting. अभी shoot करिए. Now you see, मैंने just tilt किया है, and you see the difference between the two. The needle tip already is coming out by 1 millimeter.
This was because
I've tilted the head. So what I'm trying to emphasize is, even if the book is saying that 3 to 5 millimeter inside the clivus, but the position of the head itself can change the position. Shoot करिए अभी. Now you see you are gone beyond the clival line.
yes.
So let us not go beyond the clival line, so that under no circumstances we are complicating the patient. Okay, now we want test stimulation. I hope the audience has understood what I was trying to say.
Yeah, but in that case, how do you know what is the optimal position?
Yeah, so optimal position, obviously the best sharp clival line, that should be the correct position. And we do not go beyond the clival line. Shoot कीजिए एक बार और. Sorry, एक बार और.
Is there any role of taking AP view? Yes, AP view or submental view?
हाँ, लिया था ना अभी अपन ने राजीव. चलो अभी टेस्ट स्टिमुलेशन अभी करके दिखाया था ना मैंने. हाँ, 0.3. राजेश जी दर्द हो तो बताइएगा अभी. हाँ, आ रहा है, ठीक है. कितने पे किया? ओके, 0.2 पे ही आ रहा है. कहाँ? वहीं पे है जहां पर होता है आपको.
Can you show us the?
इधर भी है. ओके, सो ही हैज इट एंड V1. अभी इधर है क्या दर्द?
Yes.
इधर नहीं और इधर है. तो he has pain on both V1 and V2. So just for his safety, 65 degrees. And now you can push.
Impedance is also correct.
Yeah, impedance should be 300 to 500.
300 to 500.
Yeah.
You are planning to give the first cycle at 65.
Yes, 65. Huh?
And duration?
Data alag. Please start. You have given the drug, right?
For how much duration you are planning to give?
60 seconds.
60 seconds. Okay.
Yeah. So he is having pain, huh?
do you tend to give larger temperature also apart from 65? Yeah, 65 is a standard.
75.
I use 75 because this is V1, I don't want to damage. So I am using 65, but now like for V2 I'll give a 75 shot.
So can we go higher up for V2, V3 even more than 75?
80 at times 90, but immediately the complications you will see would be higher. मतलब आपको numbness, so these days for last 5 years or so, the literature is that numbness, if the numbness is coming in the initial time, your response rate would be better. I'm sorry. So numbness, but the numbness should correct itself. Now, bus. So pull it out a bit now. Pull it out a little. Now we are pulling it out. One shot has been done. Shoot, please.
We have the vertebroplasty demonstration going on at the Synthesis stall. So somebody who wants to do can do it.
Bus. Shoot.
Whoever is interested can go to the Synthesis stall outside near the dining area.
Okay, this is the second point. So test stimulation. We are giving a test stimulation again. Let's see if he is winking. Yeah, 3.
Please show the machine in the main screen.
राजेश जी दर्द आ रहा है? ठीक है. Okay. अभी यहाँ आ रहा है क्या? So now he has V2. इधर है क्या? हाँ? इधर भी है. Okay. So I'll pull a little bit more. Shoot. बस ठीक हो जाएंगे आप.
In between the 2 cycles, you should always do stimulation.
Yes, obviously. चलो अभी टेस्ट स्टिमुलेशन प्लीज. ऑन है. सुनिए राजेश जी, दर्द है अभी? दर्द हो रहा है? कहाँ? ठीक है. हाँ ठीक है. ओके. So shoot please. Okay, so this is the second spot we have decided on, and okay, 75 degrees.
Compared to the first cycle, you have slightly withdrawn the needle for the second cycle.
Yes.
Okay.
Shoot. So when you are giving the current, keep a watch on the temperature that you are achieving. So right now we are achieving 76. 30 seconds have passed. The impedance is 316. So all the parameters are like aligned well. Yeah, done. Ravi, you want to remove it. So big round of applause for Datta.
Wow, Dattaraj has shown the accuracy with his robotic arm. Hopefully, none of us have here. So, but Dr. Ashish, it was a great demonstration, by the way.
Thank you so much. Thank you.
Sir,
बस निकाल रहे हैं. राजेश जी निकाल रहे हैं.
Dr. Ashish, one question.
Yeah.
Sir, is there a role of gamma knife in your practice, or have you been any?
Yeah. So as I was mentioning in my lecture, gamma knife has a definite role. So I don't do it. I don't it is not my first choice. But if the patient insists, then I do refer him for gamma knife. But it is not the first of the choices in my armamentarium. It is still medicine, RF, MVD.
Wait.
Chalo, I think we are done.
No, wait. Patient is not dipping fast now.
Why you want to rush him? Yeah, please.
Hello. Hello, sir. आशीष सर.
राजेश ठीक है आप? आराम आया आपको?
You have a question?
आराम है? चलिए, thank you, बढ़िया, good. So our patient is fairly happy.
Dr. Ashish?
Yeah.
Sir, there is a question from the audience. They want to know where to keep the needle position in the lateral projection for V1, V2 and V3. You can just explain
इधर
it.
दिखाइए. So the Gasserian ganglion is something like this. Okay, sitting on the petrous area and clivus gives us a very good idea. So try not to go beyond the clivus, and so the clival line and just above it is V1. Then around 2 to 3 millimeters below would be V2, and further lower down would be V3. So 3 millimeters के gap में V1, V2, V3. But if you get such a patient who's cooperative, then he himself will tell you where exactly paresthesia is. So that position of the needle should be the best position. That's number one. Can we have the AP?
So basically it is guided by radiology and most importantly the patient himself.
Yes. And secondly, there are this one. Few lectures, few papers which suggest that in the if this is the foramen ovale, laterally you will have lateral and inferior you will have the V3, and on this side you will have the V1.
So does this tip in the proximity of V3 in AP view then?
Can you show this V1, V2, V3 in AP view again?
Yeah, so posterolateral would be the V3, and as you move towards the midline, you're moving towards V2 and V1.
Okay.
Here.
Hello, can you hear Ramesh?
Yes, Sattaraj, please continue.
So Dr. Ashish, it was okay. So it was a great demonstration. Everybody enjoy your demonstration, and I hope there are no further questions from the audience here. So a big round of applause to Dr. Ashish and team. Sir, I hope you can hear the applause.
Thank you so much for the appreciation. Extremely thankful. And once I join there, if there are questions, I'll answer.
Sure, sir, sure.
Thank you, Raj.
Dr. Ashish, one case is there waiting for you in OT1, the lumbar. Case is already shifted there. So Dattaraj and Dr. Ashish team can go to OT1. Dattaraj, you owe us a party for your first. Hello?
राजू बाद में बात कर लेते थैंक यू
OT1 में चले जाओ, OT1 में लंबा केस लग गया है.
OT1 में ही है हाँ
अच्छा ठीक है, ओके. तो somebody can present.
हाँ ठीक है.
Who is presenting the case? Who is presenting the case?
अरे इसमें थोड़ा कॉफी डाल देते हैं. चीनी है.
Abhishek is there. Abhishek.
Hello.
Who is presenting the case, bhai?
Yes, sir. Ashwin here, sir. Patient is. Yes, sir. Am I audible?
Yeah, you are audible, please.
Sir, patient is 54-year-old female.
We are not able to see your PPT.
Yes, sir. Is it visible now? Patient is 54-year-old female. Presenting with complaints of lower backache related to bilateral lower limb for the past 1 year.
Your PPT is not visible.
The last case है
41.
last 41 sir
दो लंबा है
एक ही कर दो मरीज का इलाज हो जाएगा
वही इसलिए कराया हुआ है सो
हाँ कराए सर
Yes, sir. Is it visible now?
Ravinder, can you arrange? We are not able to see his PPT.
अजय सर OT नंबर 1 कनेक्ट करा दो.
We are still seeing OT-2 only.
अभी क्या टाइम है? अभी तो 11:30 हुआ है.
हाँ तो भैया 1 घंटा लगेगा चेंज भी करेंगे
हाँ, क्या चेंज करेंगे?
3 से 4
Oh my God, you're a big man. सपा में.
We have shared a feedback form on the Google, on your group. So I would request all delegates to please fill it up.
अरे सर
Okay, we are in OT2. Who's the resident? Vivek? Who's the resident in OT2?
Sir, Ashwin here, sir.
Ashwini, which
Rajesh,
case?
Rajesh has come. Rajesh, is the patient ready? Yeah, patient is ready. You can call Dr. Ashish to OT.
And Ashwani, is this patient originally scheduled in OT1?
No, sir. She is of OT2 only, sir.
OT2 only. Which case is it? So please present the case.
Sir, patient is a 47-year-old female.
Have the slides. Where are the slides or whatever you're trying to show us? PPT. Okay, you are on, Ashwini. We can see the screen.
Ashwin, you can start the presentation. We are not able to hear you.
So patient is a 47-year-old female who had presented with lower back ache related to bilateral lower limb for the past 2 years. Her right side more than the left side. So, on motor examination, she is neurologically intact and reflexes are normal, 2+ in all joints. Sensation and bowel and bladder are intact. And on the MRI, she has L4.
Can you zoom this? Can you zoom in?
I think laptop पे present कर रहा है.
अच्छा ठीक है. So it's not.
Yeah, you carry on.
Continue.
Yes, sir. There's a diffuse disc bulge at the L4, L5 level, as well as L5, S1 with bilateral foramen compressions. So, patient is planned for transforaminal.
What is the patient planned for?
Transforaminal lumbar block.
We can't hear you. Speak louder.
Patient is planned for transforaminal blocks or lumbar.
Transforaminal. Which side, right or left?
Since the patient has right side more than left side, patient will be planned for right side.
Symptomatic is right because in the radiology it is bilateral.
Yes, sir. Radiology it is bilateral. Sir.
But go back to the original slide. Symptomatically it's on the right.
Symptomatically on the right side, sir. Right side more than the left.
Where have you written? It's not there.
You have mentioned bilateral lower limb radiculopathy, right?
Yes, sir. Symptomatically, she has right more than left.
But now you are saying on documentation there is nothing written right. Radiology also nothing right. Exclusively. So Ashish, are you there? Get Dr. Ashish on the mic.
Yes.
Dr. Ashish?
Ashwin?
Yeah, hi.
Ashish, you have gone through the radiology of this patient?
No. I'm still waiting for. I am still waiting for the radiology. We just have SAG cuts, and on SAG cuts, basically L4-5 में दिख रहा है.
Right.
More so on central, but we are just waiting for axial cuts to come.
Okay, so if it is bilateral lateral recess stenosis, what would you prefer?
So ideally bilateral, you just have two options, either go bilateral transforaminal or you can go bilateral paramedian or a midline interlaminar.
Midline interlaminar means epidural.
Exactly.
So,
but let us see, because her pain is more on the right side.
More on the right side.
Yeah.
So let us do a right transforaminal.
So unfortunately, we have lost the axial images. So let me study the SAG.
Maybe on the PPT you have?
See, Deepak, what I feel is, because the patient has more right-sided symptoms and there is a L4-5 component to it, which appears to be more, and I can see a root being pushed clearly on the sag. So the plan would be to just go in do a transforaminal right-sided block.
Okay. Okay, understood.
Yeah.
This question is for Ashwin. Ashwin, in the OT list which has been there on the, which case is this? Is this case 6 or case, because there's only one female.
Cleaning के लिए देंगे.
Sorry? Case 4 is written as 49 male. So is that the same case we are talking
आपका नाम क्या है? So the patient's name is Seema. She is around 45 years old and she has right-sided pain for last 2 years. This
Okay,
is the
so
history.
maybe they have just changed the sex by mistake. Ashwin?
Cleaning companies. So, Rajiv, what do you want to do? Lamba wala? ठीक है, come.
So I think we can see a transforaminal again. Just to, because yesterday we saw many, but today just to reinforce, everybody can see a transforaminal block.
ये सियाम आप देख रहे हैं, उस तरफ ले जा पाएंगे? या, ठीक है, या बस, नहीं, ठीक है. So I'll just sort of act like a repetitive record that just look at the AP, see where the leg crest is for the long approach, and because that would decide the position.
Can you repeat again? Actually, the sound quality suddenly has deteriorated.
Is it okay now?
It is not, something wrong in the system. But anyway, just speak a little louder.
So basically on AP we have to look at the location of the iliac crest to finalize the entry point. Apart from AP and just lateral to look at the facet joint hump.
Okay.
Yeah. Sure, Ajay.
So patient is lying prone. There is just one, I would say, pillow under the abdomen. That's right?
No. For transforaminal, as I was saying yesterday, we don't require any bend or any curve.
Right.
It's just straight. So she's lying absolutely
straight.
Straight.
And hands are over on the pillow. That's the way you like it.
Yes. So can you see the patient's image?
Yes, we are seeing. We are seeing you also along with the patient.
Okay, so we are trying to shift the C-arm onto the left side so that I have working space here.
Right.
And we'll get the AP and lateral shot. So we have finalized to do a L4-5 long needle approach. Ravi, मेरे needles कहाँ रखे हुए हैं?
Now Ashish, you were remembering the old days.
Yeah.
And when you are thrust into a OT last minute.
Yeah.
Without any clue.
No. You are just easing it out. So the whole story is Sujoy Sanyal getting me into Mehta Sir's OT. That's the true story. And finally for an aneurysm.
This is nostalgic without any pressure on your head.
We wanted to recreate the whole nostalgia, Dr. Ashish.
You have successfully done it. इधर आइएगा. Needles वहाँ लेके आए क्या मैं? उधर लेके आऊँ क्या? रुको, let me check myself. Looking for the needles. तुम्हें वो चाहिए. नहीं ये वाला नहीं, मेरे थे ना. पैकेट्स रखे थे. ये वाला. And
आशीष
हाँ
सर
ले लेता हूँ ये कैनेटिक अनस्टेराइल है तो कल मुझे दिया गया है साइडेक्स में है तो साइडेक्स में डाल दो साइडेक्स में डाल दो So Deepak, give us just 5 minutes.
Yes, yes.
We'll get things ready. Can I get a marker, please? Can I get a marker?
Has Rajiv reached?
Yeah, he's scrubbed.
Okay, great.
Chalo, can you shoot, please? Okay, rotate. Yeah, good. Now flip it left, right. Okay, now push it towards me. अभी एक मिनट है. Okay, shoot now. Okay, थोड़ा सा और लेके आओ मेरी तरफ और इसको ऊपर कर लेके करो. शूट. हाँ, और थोड़ा सा हेड की तरफ ले जाइए. हाँ, और टिल्ट भी करिए थोड़ा सा ऐसे एंगल में हल्का से 5 डिग्री. ओके बस. यस. हाँ, शूट करिए. ठीक है, ये बढ़िया है. तो अब हम थोड़ा और ऊपर लेके जाते हैं. सो जस्ट पुश दिस यहाँ टुवर्ड्स मी थोड़ा सा. सो प्लीज लुक एट द लोकेशन ऑफ द iliac crest. शूट. So we are. So even if I come here, shoot please. Okay, so I am fairly above the iliac crest. Marker pen. Thanks. Niche, I'll try, but it is not easy. Yeah, I can do it, but you know, it's a lot of struggle. Lateral kar lijiye.
Sorry, Ashish, what?
So Amol was asking that can we lateral please? Can we go from this location for a L5S1 block as well? So as I said, it is possible, but I'll just show you what are the 3 structures that prevent us from doing it a smooth one. One is this transverse process, the other is the sacral ala, and the third is the iliac crest. So what happens is when we are coming, it's a very narrow band through which we have to go. Okay. वो दिक्कत तो होती है. शूट करें. क्या? We may be, लेकिन I think looking to where the iliac crest was. थोड़ा सा शूट करिए. ठीक है. So I'll select this because just want to stay a little above the iliac crest. Okay. Local please. Straight.
Dr. Ashish, yesterday as we were discussing, we want the needle tip to be at the hump.
Yes. So basically कहाँ गया वो वाला दिखाएंगे क्या? सेव नहीं हुआ. Okay, I'm sorry. Okay, shoot please. Okay, so the thing that I wanted to show was we are going a little higher up, but the needle is almost to the hump. So this is the spinous tip of the spinous process.
Yes.
We are almost at parallel to the same line as the hump.
Right.
Okay. Yeah. So we will do a transforaminal L4-5 and we will try for an L5S1, but the success is.
So what I understood now is the hump is not the point. The line which is connecting the humps is the one which you're.
Yes. So basically lateral, what we decide is how much anterior can we go, or where posteriorly. So we don't need to sort of be on the same point.
Right, and
That is-
because the foramen is right from the midpoint of the body of the vertebra.
Yeah, to the lower body.
So you can go anywhere.
Yeah. Okay, local please.
Basically in between the two pedicles actually.
So I have cleaned it. We'll do मैडम एक सुई पता चलेगी.
Came in triangle. Far lateral.
You are doing infrapedicular, Ashish?
Yes, I will. No, not subpedicular. I'll go infraneural.
Infraneural.
In the Campbell's triangle. So always I use that place. So if you look here.
Yes.
So this is, so the nerve root is coming like this. So what is the Campbell's triangle? This is the nerve root coming.
AI को दूसरी साइड में शिफ्ट कर दीजिए.
हाँ, now it's okay.
So you see the exiting root, that is the L4 root for L4-5 is coming out like this.
Right.
So obviously I'll stay below this. So this area becomes one of the safest for me.
Okay.
So the exiting root, the theca and the lower body ka upper end plate.
Right.
Those are the three areas jahan hame we have to focus. Okay, betadine please. Sister, are we ready with the needle?
So, Dr. Ashish, if we see in the lateral view, so you are targeting the lower half of the foramen?
Yes.
Okay, can you show in the lateral view?
Yeah, why not?
Yes, please.
So I'll target, see, as I was telling, this end plate is the sweetest spot for me. Okay, so if I am somewhere here, I am not going to injure the root, and also I am not going to enter the disc. I will remain in the foramen.
Okay.
So this area is the sweet spot.
Okay, then near the lower end plate.
Lower end plate of the upper body.
Yes, right.
Chalo, drape please. Yeah, sister, needle ready. हाँ बस perfect. बस body. Perfect. Specs के लिए. Load 1.5. You load about 3 ml. Yeah, 2 ml. And maybe saline. That's if we require.
सर को कोरोना की क्यों पीछे पड़े पता नहीं.
पूछने के लिए So Rajiv, see, because our entry point is a little above the end plate, है ना, end plate के ऊपर है ना, so you have to direct it caudally and you have to direct it a little towards the abdomen, halka, so you will enter into the foramen. Sterilium please. Sterilium please. Thanks. feel आएगा, आपको थोड़ा सा gritty feel आता है. That is because we feel that foramen is an open space. It is not. There are a lot of intraforaminal ligaments which hold the neural structures, which hold the vessels. So when you're going through, you get that feel. Excellent. So you come on this side, so that because this is where you need to target. Can I get a gauze, please? Yeah, thanks. So see, Rajiv, this is nearly the point we have to go. Either, and you are here, thoda up. So as you go, so you have to take the bevel is directed towards the left. The tip is towards the left for us, and you have to go a little down. Okay, chalo. Bus, that's it. Now adjust the location. मतलब हाथ ऐसे कर. So we are starting. Right. Chalo, take it in. Rajiv is at the helm of affairs. He's getting a first-hand experience. So, okay, Rajiv, हाथ हटाना. Let's shoot. हाथ हटा लो, नहीं तो हाथ आएगा बीच में. Shoot, please. Okay, so you see, you are like way superior, मतलब posterior. You have to go much more anterior. तो उसके लिए basically bevel को कर लो, ऐसे और ऐसे ये इससे होता है. So the sharp is beyond इसके नीचे. तो इसको ऐसे कर लो, तो and you go. Up, lift your hand further. Now go. After say 1 inch, we'll shoot again. Sorry, madam. Bas. Are you hitting a bone? No. Chalo. Shoot, please. So you are better. You're better, but still, let me adjust a bit.
So you will go superior now, cranial direction.
Little bit cranial and sort of anterior as well. Shoot, please.
Okay, we are still posterior.
Yes, we are still way posterior. Shoot. Yeah. ठीक है हाँ. अभी but you are a little sort of going inferior. Though not a problem. You can even go there. There's no root there. Bas shoot karo. Let's see. Okay, now wait. Okay, now let's get a AP because AP is more safe than lateral. Especially if, see, the lateral is safe till you are posterior because bone is your friend. But the minute you come towards the foraminal area, you should know. Yes. Yeah. Nerve is, yes. चलो 5 डिग्री एंगल कर लीजिए. या ओके. वो वाला एक्सरे इधर नहीं आया क्या? चलो ठीक है, ये दिखाओ. You can, no, I mean, you can decide where you want depending on how you want the needle. वो AP दिखाइए please. Okay. No, you don't decide on the film where the bevel is directed because even if it is right or left directed, so look at the point here. सो ये देखो, ये अभी तुम्हारा बेवल जो है वो लेफ्ट डायरेक्टेड है, अब नीचे है वो, पर दोनों में तुम्हें फिल्म में वैसा ही दिखेगा। सो शूट करिए। ओके, दिस अपीयर्स टू बी अ बेटर लोकेशन। शूट। ओके, नाउ राजीव, यू विल गेट अ फील ऑफ द फोरामेन। ठीक है, धीरे धीरे गो इन एंड हाँ, यू कैन, बट यू हैव टू नो, थोड़ा और बाहर ऐसे। हाँ, चलो चलो, शूट करते हैं। शूट प्लीज। हाँ हाँ, अब हाँ, ठीक है, यू आर ऑल वेरी एट अ गुड पोजिशन इफ यू आर इनसाइड। और डालो अब अंदर। बस मैडम, बस। शूट। Yes, you are entering. Very good. Firm. Shoot. ठीक है, you are in a good position. Let me adjust. No, ये ना अपन गलत है। ये बोन फील हो रहा था राजीव तुम्हें। हाँ, ये बोन है। शूट करिए प्लीज। नीचे नहीं, बेसिकली आई थिंक आप अगर आपको लैटरल वाला वो वाला फिल्म देखेंगे ना, तो यू माइट बी हिटिंग द बोन देयर, सो वी हैव टू गो या मोर सुपरफिशियल। यस यस, शूट प्लीज। ले लें। हाँ, शूट प्लीज।
नाउ आई थिंक यू आर इन द फिल्म।
यस, आई थिंक सो। शूट प्लीज। ओके, लैटरल करिए, बट वी मे बी अ लिटिल एंटीरियर एज वेल। चलिए, एक लैटरल कर लीजिए। सॉरी, बेवल ये है, ये ठीक है। इन एनी नीडल यू विल फाइंड दैट। सो द पॉइंट, जहां पर पॉइंटेड एंड है वहां पर वो जाएगा। ओके, यस यस यस। Okay, see, what I was telling was it's a little anterior.
Right.
But you know, Deepak, this is one of the ideal or good positions for a transforaminal docking.
Right.
Because you want to be in this area to remove those disc fragments. So what we'll do is...
So you can feel the bone here?
Yeah, still no, I think it could be the disc.
Okay.
Yeah, so what I'll do in here is, I'm withdrawing it a bit. I am taking it a little cranial and superficial and going in. दिखाइए कहाँ है? Okay, this looks a little better. AP कर लीजिए। हाँ।
वो लाइन क्या आ गया? लाइन कपड़ा छपा था ना, कपड़े
No, with half of the body, because you have the psoas there, so थोड़ा सा tilt कर ले। हाँ, shoot कर। ठीक है, so we are inside the foramen and not in the disc.
Right.
Okay, so let's push it. Yeah, but how will I check it? करो कोशिश करो। शूट प्लीज। हाँ, डालो फिर से। सो शूट, बस बस बस, सॉरी। शूट प्लीज। So Rajiv wanted to have another feel of it, so he withdrew and he has inserted again. But now we should have a look again at lateral to see where we are. So just get one more lateral. Shoot. See, we are in the disc.
Right.
You got it, Rajiv? हाँ तो वो हाँ नहीं पीछे और सॉरी अभी मत करना शूट.
That means we just need to withdraw it a little bit.
We will withdraw it and we'll keep it more superior, so posterior rather, and we want to go a little bit more cranial as well.
Right.
So let's see. Sorry, दिखाइए. Okay, this looks better. But yeah, but can any one of you tell me why the patient winced in pain? There is no nerve here. Why did the patient wince in pain?
Traversing.
No, not traversing, most likely because I might have touched the annulus. And annulus is a very painful structure. So let's see, we'll on AP कर लीजिए. चलो ये AP कर लो फटाक से. Let's finish on. Little bit, क्योंकि हम काफी अंदर है ना फोरामेन के अंदर. बट वो होता नहीं है because drug also causes some fullness. चलो AP shot please. Okay, not very good position, but ठीक है, we like try to accept it depending on the diaphragm. दिखाइए. Okay, we can see the root and the drug is going inside.
Inside where?
See, एक अभी मैं और डालता हूँ तो you will see a streak better. Shoot please. So you can see the root, right?
Yes, yes.
And then there is flow inside the epidural space as well.
Yes.
Yeah. बस. Drug. Drug. Sensorkin. Bupivacaine. तो इसको ओके तो आप इसका 1.5 ml ठीक है 1.25 ml दे दो लगभग.
वो निकल गया
डेक्सा प्लीज. और जाओ बस डेक्सा चल रहा है. चलो डाल दो थोड़ा सा. विल टेक बस. चलो शूट प्लीज. बस. So there is it has flowed out. So I think we must have achieved some epidural as well as good transforaminal.
Right.
Chalo, okay.
Is it possible to go to the opposite side with this if you put lot of anesthetic or this thing?
No, I don't think so.
No.
Remove it. So I wanted to show a L5S1, but I think she is having a lot of apprehension.
Okay. Also, Ashish, I wanted to ask if you put in a catheter through this, and just hypothetical question, will it go into the epidural space?
Come again, Deepak.
If you put a catheter, epidural catheter through this, will it go to the opposite side?
Truly speaking, Deepak, I have never done it, so I don't have the right answer. So I'll rather. So what's the program next week? I come there and
yes, we can have a small discussion with you.
Okay.
Interaction with the audience.
Okay.
So you come immediately and then we'll have a closing ceremony.
Okay. Reaching.
So we are waiting for you to come fast. Any questions? So those who have not filled in the feedback form, please take this time to fill in the feedback form. कोई प्रॉब्लम नहीं So apparently they have shift to OT1. They have a case, another cervical waiting. Maybe they can finish that also. OT1 में shift करो. So Ashish, So what has been decided is he's just delivered the message that after Ashish Tandon talked to the patient, they feel it was better served by medication than by giving a block. So they have cancelled that case. So this is so Ashish Tandon will come and be deliver the session. But I think the patient is foremost. For whatever reason, it's not that we should unnecessarily do any procedure when it can be managed by a procedure or a medicine which is one level lower than that.
सर आपका DRG प्लस तो उसमें ट्रांसमिशन अमाउंट उसने परसेंट करके ट्रांसमिशन नहीं है उसका पता करो
We actually have a third case going on for dresotomy, but unfortunately the transmission is not there for that OT. So we are seeing if we can show, then will show that final dress procedure to you. If microscope, even the transmission from microscope is available, then we'll be able to show.
सोमनाथ को ठीक है सर
So, if we have this workshop next time, I would like to know what other procedures would any of you like to see besides the one we have already shown. Have you got any other wish list? Sorry? Neurectomies you would like to see, okay. Oh, okay. Carpal tunnel, actually Dr. Sharat Chandra, one of the unit heads, he has also innovated a device for minimally invasive. So that is okay. I understood carpal tunnel and coccydynia. Brachial plexus what? Neurotizations. Okay. That we have a separate, conference. That itself is we have the annual conference of brachial plexus surgery in January in AIMS Raipur next year. So that is, we have that already going on. But for pain procedures, anything else? Spinal cord, no. Yes, we had thought that we might have, but we didn't have an appropriate case this time. So, Ashish, please come here. So I will keep that in mind next time when we'll have, besides these procedures. So, first of all, I thank Dr. Ashish for a beautiful demonstration, especially a neurosurgical perspective, because there are so many neurosurgeons here, and we are not basically doing justice for these kind of patients. And this is the very, I would say, low-hanging fruit for a neurosurgeon in terms of relieving pain. And especially, I think in institutions like ours and AIMS, where we have these patients whom we give date for surgery, and we have a waiting list of 2 years, 3 years for this surgery. So in the interim, all these procedures can be really nice. Also for trigeminal, because when we give a date for MBD, they get admitted after a year or so. So it might happen that most of these patients may not require surgery when they come after a year or two. Anyway, all randomized studies have shown that for any disc pain, if you do anything, at the end of 2 years, he will be better. So if we give these pain procedures, everything is based on the acute treatment of pain. So I think we have learned a lot from both Dr. Dureja and Dr. Ashish, and we have got two perspectives. It's very important to have a different perspective so that you can have a balanced view and decide what you would like to do in your own practice. You can see the pros and cons of everything, and I think especially for trigeminal neuralgia, we heard his Dr. Ashish's perspective that why he likes sedation, and I would agree with him, because we all have a learning curve, and when we are doing this, we might, if the patient is screaming and turning around on the table, it makes life difficult. So if we have sedation available, it makes it very easy, and we are already so used to doing everything under anesthesia that it will take us a little bit of time to go on to completely local toker, whatever you call it. So Ashish, your comments on, we would like your views that you have been doing. Ashish is an alumni from AIMS only. We are almost batchmates, and it's been, I think, 18 to 19 years that he has been in practice. So his journey, obviously he does a lot of endoscopies, as you must have heard on his talks, but his journey has which transformed it into a pain specialist also during the last 2 decades.
Yeah, so basically, first I'll give you why I started RF. So I was trained under Professor Gentili and Professor Teo, and we used to do keyhole. I learned skull base and keyhole surgery for trigeminals and CP angles, etc., etc. But I never had patients, so I was just doing about 2 or 3 MVDs per year, and that was almost 5-7 years. So I just asked myself that there's something wrong. There's so many trigeminals and they don't come to me. They come to me, consult, I advise them surgery, and I never see them back. And now I'm doing almost 1 to 3 RFs per month. So if you look at my numbers, there is a huge shift over the years. And that is why I would request all of you to take up RFs or these procedures, because the patients agree pretty fast and you are not losing the patient, and that's the practical part. And the other thing is, if the results are very different, then you may think, okay, look, I am still with MVD. But if the results are so similar, then why not if the patient is agreeing to it? So that's for trigeminal. So as far as lumbar disc and lumbar pain and neck pain is concerned, one very important patient sort of pulled me into the pain practice. So there was a moderately large disc and the patient had EHL weakness. This was way back in 2008 or 9. And I told him that, look, you need surgery, you need urgent surgery, we don't have anything else. 15 days back, he comes to me that I am absolutely fine and I have no pain and I have got my sister for headache. So it was such a major shock for me that I am pushing for surgery and he comes to me and tells me that in 15 days he's been fine and he received a block. So that sort of jolted me and told me that I need to change something in my practice. And then obviously we should have all the weaponaries with us. If we are not ready for that, especially in private practice, then you are missing a lot. And so if you are doing 30 to 40 cases a month or 50 cases a month, and if you are losing 2 or 3 patients, that means you are losing almost 10% of your patient load. So you need to expand your repertoire. That's what I feel. The second aspect which I try to push in these 2 days is getting young people to do and show to all of you that you can very easily go back and do it. If I can do, if Rajiv can do, if Datta can do, then all of us can do. And we have a much better anatomical perspective because we are also going inside looking at the anatomy. So that 3D vision जो हमारा बन जाता है, that is much better, I feel. So I would urge all of you to get into it, and I hope we are able to take our neurosurgical field to higher levels. Also, I would like to present my extreme thanks to Rajiv, Deepak, and the whole team for inviting me. It has been an honor coming back. It's like a dream coming back to your alma mater and going to the same theater, meeting the staff. So I'm extremely obliged. Thank you so much.
Good afternoon, everyone. With this, we conclude our sessions for the day today. And as today's day was only half day, so with this we complete our workshop proceedings. And the summary of this workshop, which I could make out from my mind, is it might be different from for everyone, but for my mind is as a clinician. As a pain, I think everybody is a pain specialist because at least 70% of everyone's patient is related to some sort of pain. So that's why we all should have some good idea, not some idea. We should have good idea about pain. And as we are all a significant number of us amongst us are neurosurgeons, so these are all good practices. We should expand our armamentarium as Dr. Tandon has just highlighted to us. So with this, we conclude the proceedings of the workshop, and I am very, very thankful to you for coming so far off, leaving your work, your practice for not 2-3 days, coming and going, including, and contributing significantly to this workshop. Your feedback will be very important to us, so I request you all as early as possible, please send us the feedback. And with this, thank you very much from bottom of our heart. The whole team of ISPNS and including President Dr. Indra Devi, Secretary Dr. Deepak Agrawal, and the whole ISPNS team, thank you thank you much. And we will invite you further for such whenever we organize such conferences in future. Thank you very much, and we all can have lunch. Lunch is ready. We can have lunch outside in the dining hall. Thank you very much.